Welcome to session 8, that is on nutritional disorders. In this session, we are going to look at Kwashiorkor, Marasmus, and overnutrition. That's the reading list. Marasmus. The term Marasmus is derived from the Greek word marasmus, which means withering or wasting. It's a form of severe acute malnutrition in which there is insufficient intake of protein and calories. In children, it occurs mostly during the first year of life and is a form of protein energy malnutrition. The causes are failure to breastfeed. So if the child refuses to breastfeed or the mother refuses to breastfeed the child can be malnourished or have marasmus. Condition of the breast, insufficient diet, improper feeding habits, emotional deprivation, metabolic abnormalities, congenital malformation, lack of education, and infections. So all these can lead to marasmus. Signs and symptoms, we have growth retardation. Compared to age, the weight is actually low compared to the age of the child. There is prominent bones, there is skinny limbs, there is muscle wasting, loose wrinkled skin on lifting. Then you have loose wrinkled skin around the buttocks. That is usually termed as baggy pants. There is sunken eyes. There is sunken face with eyes sinking into sockets, giving appearance of a small old man's face. So this is the baggy pants that I'm talking about. Still on the signs and symptoms, hair remains the same. The child is less irritable. The child is alert and frightful, has good appetite, and is always hungry. So this is an image of a child with marasmus. So you can see the hair, you can see the skinny limbs. And so another one, also the hair is the same, but we can see the skinny limbs and so on. We'll move on to Kwashiorkor. Kwashiorkor is a protein deficiency disease. The term Kwashiorkor is taken from the Ga language of Ghana, and it means the sickness of weaning. Edema is characteristic of Kwashiorkor, but is absent in marasmus, and it's high during the second year of life. The causes are ignorance. Sometimes they don't know the right diet to give the child. So as a result, the child ends up in having Kwashiorkor. Food habits, economic factors, and infections are all causes of Kwashiorkor. Signs and symptoms, there's growth retardation, there is edema. It starts with swelling of the feet and then the whole leg and hands and feet. The face is normally round, giving a moon face appearance. There's watery stools, and there is muscle wasting, which is usually not visible due to the edema. So this is a patient with Kwashiorkor, and it's being tested for edema. So another picture of a patient with Kwashiorkor. Look at the abdomen, look at the hair. The hair is silky. Yeah, so the skin changes that I'm going to talk about is very soon is what you are seeing on the screen. So there is mental apathy. Unlike marasmic patients who is very interested in the environment and is alert, for Kwashiorkor patients, they show less interest in their surroundings. For the skin, there is hypo or hyper pigmentation. There is ulceration, spreading over the limbs, the thighs, the genitalia, the groins, and behind the ear. There is exudate lesions resembling severe burns. There is weakness, there's loss of appetite, and reddish brown silky hair, which is easily pluckable. And there is pallor. How do you diagnose Kwashiorkor and Marasmus? You use the weight for length or weight for height. So if it's less than 70% or less than -3 standard deviation, you can diagnose the child as having Marasmus. Kwashiorkor, you can use the edema of both feet, or you can also use the MUAC tape to measure whether the child is malnourished or not. So this is how the MUAC tape is being used, and last semester we talked about it, so I'm not going to talk about it this time. Measuring the height, this is how you go about it. Then management. Community-based management of acute malnutrition. It has 3 elements. We have the community outreach, outpatient care, that's the home treatment, then inpatient care, that's hospital or health facility treatment. So the community-based management for acute malnutrition offers severely malnourished children the opportunity to be treated at home. It's not everything that we have to do it at the hospital. You have to treat at the hospital. Sometimes when you educate the mothers, they can actually take good care of their children at home. But they need support. The family and the community need support. So you don't just leave them, you support them during the treatment. Health professionals assist community members or communities to diagnose nutritional problems and oversees community level activities. So they use innovative food products called the ready-to-use therapeutic food, RUTF, and this is what they use at home. Treatment can take place in the community at any time and any place, resulting in a shift towards new outpatient treatment program known as community-based management of acute malnutrition. So this is what I was talking about. This is the food that they give to them. It's ready-to-use therapy food. They are peanut butter-based paste and biscuits that are nutritious, enriched and packed with high concentration of protein and energy. So this is what they use in treating the patient. So nutritional education, you have to also educate them, which include information on optimal infant and child feeding care practices as they are using the food. You have to educate them. You advise them on hygiene and sanitation and prevention of illness and psychosocial support. Then the weight and height of children with moderate acute malnutrition are monitored in order to prevent deterioration into severe acute malnutrition. So as they are actually using the food at home, the health professionals need to monitor their weight and height to prevent the child from deteriorating. So that is that for the community outreach. So the outpatient care, home treatment, children treated with community-based outpatient care represent 80% of all cases of acute malnutrition. Those who are clinically stable, have no medical complication, and still have appetite are directly admitted to a program of home treatment, supported by weekly visits to stabilization centers, either the hospital or health centers with qualified medical supervision. Still on the outpatient care, recovery, still on the outpatient care, that's a home treatment, weekly visits to stabilize centers allow health professionals to evaluate children's progress and provide them with weekly supply of the food, that's the RUTF, for home treatment. They receive systemic preventive measures and treatment for infections. So when the health professionals go there, they supply them with the food, as well as they receive preventive measures for treatment of infections and micronutrient deficiencies, such as antibiotics, vitamin A, dewormers, and immunization. And weekly follow-up visits can continue for up to 2 months, depending on each child's progress and recovery. So for inpatient, we have talked about community, we have talked about outpatient. Now we are going to look at inpatient. Inpatient care is hospital or health facility treatment. And usually for a child who does not have appetite, does not gain weight, or exhibit serious medical complication. So in this case, the child needs to be admitted and treated at the hospital. The child does not have appetite, is not gaining weight, and is exhibiting serious medical complication. This child needs to be hospitalized and treatment given appropriately. Such children represent only about 20% of cases of severe acute malnutrition. So we have a plan for them. The plan will look at hypoglycemia, hypothermia, dehydration, electrolyte infection, micronutrients, initiate, feed and catch up growth, sensory stimulation, and preparation for follow-up. We say a child is hypoglycemic when the blood sugar is less than 3 millimole. So what you do is you give the first feed, that is F75, and if it's quickly available, and continue with 2 to 3 hourly. So that is what you, so this is the recipe for the F75. We are not supposed to prepare it. It's been prepared by the pharmacist, but our duty is to give it to the children. So this is the recipe for F75 and F100. So for the initial feeding, day 1 to day 2, you give 2 hourly feeding, and it should be 11 mils per kg per feed. In a day, the child should have 130 mils per kg per day. From day 3 to day 5, it should be 3 hourly. And for each feed, it should be 16 mils. And in the day, the child should have 130 mils. And from day 6 onwards, the feeding should be 4 hourly, and it should be 22 mils and 130 mils per day. So that's for hypoglycemia. You can also give antibiotics, and you can give IV fluid as well. Hypothermia. You have to treat for hypothermia. Make sure the child is clothed, including the head, cover with warm blanket, and place a child under a heater. In Ghana, we don't use heaters, so we'll use a blanket. You can also put the child on the mother's bare chest or abdomen, that is skin to skin contact, and cover them with warm blanket or warm clothing. Let's look at dehydration. So if the child is dehydrated, you don't use IV routes for rehydration, except in cases of shock. So we give standard WHO-ORS solution for general use. Standard WHO-ORS solution for general use has a high sodium and low potassium content. So usually we don't give it to malnourished children, severely malnourished children. But there's a special rehydration solution for malnourished patients called the Resomal solution. And this is the recipe for Resomal solution. That one too is readily available. We don't prepare it. It's been prepared at the pharmacy shop, and all that you have to do is to go for it and give it to the patient. So still on dehydration, you give the Resomal solution or fluid orally or by NG tube, and much slowly than you would give when rehydrating a well-nourished child. So the procedure for giving is as follows. You need to read it carefully. All severely malnourished children have deficiency in potassium and magnesium. So what do? You give extra potassium, that is 3 to 4 millimole per kg daily. Then you give extra magnesium, 0.4 to 0.8 millimole per kg daily. So infection, how do you manage the infection of severely malnourished children? In severely malnourished children, the usual signs of infections are fever are often absent, yet multiple infections are common. So what I'm trying to say is that for a well-nourished child, when the child has infection, the temperature goes up. But in this case, the temperature does not go up. If the child appears to have no complication, you give Septrin for 5 days. Then you give measles vaccine if the child is more than 9 months and has not been immunized. Then you also treat for worms. You give dewormers. Still on infection, if there are complications such as hypoglycemia, hypothermia, or the child looks lethargic, you give ampicillin, that is 50 milligram per kg IM or IV 6 hourly for 2 days, or oral amoxicillin 50 milligram per kg 8 hourly for 5 days. You can also give oral ampicillin 50 milligram per kg 8 hourly for 5 days for a total of 7 days. Gentamicin can also be given once daily for 7 days. If the child fails to improve within 48 hours, then you need to add Confinicol 25 milligram per kg per IM or IV 8 hourly for 5 days. Let's look at the micronutrient deficiency. All severely malnourished children have vitamin and mineral deficiencies. So what do? You give daily for at least 2 weeks multivitamin supplement, folic acid. You give zinc, you give copper, and so on. But although anemia is common, we usually don't give iron initially, but wait until the child has a good appetite and start gaining weight, because the iron will worsen their condition. So we wait for them to improve a little before we give iron. We are on the catch-up growth, still on the plan for management. Signs that a child has reached this phase are the child is able to eat, as return of appetite, most or all of the edema has gone. Then you can say that the child has catch up. Then treatment, make a gradual transition from starter to catch-up formula. We have looked at the starter and the catch-up formula. Replace the starter F75 with equal amount of catch-up of F100 for 7 days. You can also give a milk-based formula such as catch-up F100. For the catch-up growth, you can give modified porridge or complementary feed to the child, and it should contain high level of energy and protein. Sensory stimulation, you provide tender loving care. A cheerful, stimulating environment will help them. Then the skin lesions that we saw in the previous image, what do? You actually, zinc deficiency is usual in children with Kwashiorkor, and their skin quickly improve with zinc supplementation. So in addition, you bath or soak the affected areas for 10 minutes per day in 0.01% potassium permanganate solution. Then you apply a barrier cream, and the barrier cream should be either zinc or castor oil. And then the observations that you make during admission include vital signs, daily weighing, straight monitoring of intake and output charts, signs of recovery, then eating, child eating meals. You actually observe child eating meals, then complications. Then we are still on nutritional management. Reassure mother and child, assess weight for baseline, plan diet with mother and dietitian, ensure oral care, serve well-balanced diet, encourage adequate protein fluid intake, and allow time for child to feed well. Assess weight to know if child is improving. They'll look at discharge and follow up as the last plan, management plan. A child who is 90% weight for length or equivalent to -1 standard deviation can be considered to have recovered. So the child is still likely to have a low weight for age because of stunting. Show the parent how to feed frequently with energy-rich food and nutrient-dense food. Give structural plate therapy. Then ask the parent to bring the child back for regular follow-up at 1 week, 2 weeks, and 4 weeks. Then monthly for 6 months, and make sure the child receive vitamin A. So complications, you have growth failure. The child will not be able to grow well. There's infections, there's diarrhea, there's fatty infiltration to the liver, there's anemia, there's shock and hypoglycemia. So let's look at prevention. So this can be prevented by improving maternal nutrition before and during pregnancy. Then promotion of exclusive breastfeeding is not just breastfeeding, but it should be exclusive. Then promote adequate complementary feeding. Then family planning. Yeah, family planning helps to prevent this condition. Then improve socioeconomic status or education. We are moving on to our last topic for today, overnutrition. What is overnutrition? Intake of calories beyond what the body needs for energy requirements. Example, calories taken are more than what the body needs for normal growth, development, and metabolism. So as you are taking the excess calories, is leading to overweight and eventually will lead to obesity. So etiology, diet, no marked difference. If there's genetic predisposition, the child is predisposed already, so the child can be overweight. Excessive intake of high caloric diet, inadequate exercise in relation to age, and more sedentary lifestyle. That is what our children are doing now, sitting behind computers, watching cartoons, and they are not playing. So it's going to lead to overweight. So these are images of children who are obese, and complications of obesity can lead to cardiovascular conditions, respiratory problems. It can lead to orthopedic problems, skin problems, and psychiatric problems. Still on the complications, it can lead to gallstones, social and psychological stress. Then a child who is more than 6 years who is obese, about 50% of them will be obese when they are adults. And adolescents, 80% will be obese when they are adults. So we need to ensure that children are not obese. Management. The best form of management is to prevent. will usually need to be examined carefully and endogenous cause ruled out. Then you treat any complication identified, then put child on weight loss plan. It has to do with the diet. Tips for parents: you have to tell the parent to respect child's appetite, avoid pre-prepared and sugared food when possible, then limit the amount of high-calorie food kept in the homes. Provide a healthy diet, 30% or fewer calories delivered from fat. Then you have to also encourage play, and pre-pregnancy and period of infancy should be characterized by healthy eating. Thank you.